Welcome back. Today we're tackling the second half of Station 3, the neurological examination. And I want to be honest with you right from the start. The neurology station is where more first-time candidates come unstuck than almost any other station in PACES. Not because the examination is technically difficult, not because the cases are obscure, but because most candidates have never been taught how to present neurological findings clearly. They examine well, they find the signs, and then they open their mouth, and a jumble of findings comes out in no particular order, without a conclusion, without a localization, and the examiner is left none the wiser. That is what this video is going to fix. First, the full neurological examination routine for both upper and lower limbs, step by step, in the correct order. Second, and this is the heart of the video, exactly how to present neurological findings to the examiner in a way that scores maximum marks. And third, how to avoid big mistakes. Let's get into it. Understanding the difference between an upper motor neuron and a lower motor neuron lesion is fundamental. Pay close attention to the signs relating to tone, power, reflexes, plantar response, wasting, fasciculations, and sometimes Hoffman's sign. During examination, if you find increased tone, hyperreflexia, and upgoing plantar, you should thinking about upper motor neuron lesions. Similarly, if you get decreased tone, absent reflexes, and downgoing plantar with weakness and fasciculations, you should think about lower motor neuron lesion. This is the first step to localize your lesion in neurostation. Before you touch the patient, do your general approach, just as in cardiology. Introduce yourself and gain consent. Hello, I'm Dr. Owais. I've been asked to examine your arms today. Is that okay? Position the patient. For upper limb neurology, the patient should be sitting comfortably in a chair or at the edge of the bed, arms resting in their lap. Expose both arms fully, from the shoulders down. You need to see both limbs together. Hand hygiene, gel in, visibly. Then general inspection. Stand back and look. This is 10 seconds that can tell you everything. Look at the arms. Is there any asymmetry in muscle bulk? Wasting of the small muscles of the hand. The interossei, thenar, and hypothenar muscles suggests a lower motor neuron lesion, peripheral neuropathy, or a T1 root lesion. Wasting of the shoulder girdle muscles suggests a proximal myopathy or brachial plexus lesion. Look for fasciculations, small, involuntary twitching movements in the muscle. These are a sign of lower motor neuron pathology, particularly motor neuron disease. Look at posture. Does one arm hang differently? Is the wrist flexed and the fingers extended, the classic upper motor neuron posture of a hemiplegic arm? Look at the skin, scars, contractures, deformity. Narrate this. On inspection, I note wasting of the small muscles of the right hand, with no fasciculations visible. Now move to tone. Tone is assessed before power, because if you test power first with a weak limb, the patient may not cooperate fully with tone assessment. Ask the patient, I'm going to move your arm. Please try to let it go completely floppy and don't help me or resist me. For the upper limb, assess tone at the wrist and elbow. Pick up the forearm and perform slow, then fast, passive movements. Flex and extend the wrist. Flex and extend the elbow. Pronate and supinate the forearm. What you are feeling for. Normal tone. Smooth, consistent resistance throughout the range of movement. Spasticity. Increased tone with a velocity-dependent quality. As you move faster, resistance increases. There is often a clasp knife quality, initial resistance, that suddenly gives way, like opening a penknife. Spasticity is a sign of upper motor neuron pathology. Rigidity. Increased tone that is present throughout the range of movement, at any speed. It can be smooth, lead pipe rigidity, or jerky cogwheel rigidity, where you feel a ratchet-like sensation. Rigidity is a sign of extrapyramidal pathology, as in Parkinson's disease. This is less common in PACES neurology but worth knowing. Hypotonia, reduced tone, floppy limb, seen in lower motor neuron lesions, cerebellar disease, and acute upper motor neuron lesions before spasticity develops. To check for subtle upper limb spasticity, ask the patient to perform a repetitive task with the other hand, opening and closing the fist, while you passively move the affected arm. This reinforcement technique can unmask subtle tone changes. Narrate. Tone in the right upper limb is increased with a spastic quality. Now assess power. Use the MRC grading scale, grade 0 to 5. Grade 0, no movement at all. Grade 1, flicker of movement only. Grade 2, movement with gravity eliminated. Grade 3, movement against gravity but not against resistance. Grade 4, movement against resistance but weaker than normal. Grade 5, normal power. In practice, in PACES you will usually be grading 4 or 5, because the patients are ambulant and able to consent to examination. Test power in a fixed order for the upper limb. I use this sequence: shoulder abduction, elbow flexion, elbow extension, wrist extension, finger abduction. For each movement, demonstrate first, then resist. Say, push your arm out like this, don't let me push it down. The pattern of weakness tells you the level of the lesion. Upper motor neuron lesion. Weakness is typically in the extensors of the upper limb more than the flexors. Lower motor neuron lesion. Weakness follows the distribution of a nerve root or peripheral nerve. For example, C5/6 root. Shoulder abduction and elbow flexion will be weak. For radial nerve, you will find wrist drop, finger extension weak. Lastly, for ulnar nerve, you will find weakness in small muscles of hand and finger abduction. Always test both sides and compare. Say, is this the same on the other side? Even subtle asymmetry is meaningful. Narrate. Power in the right upper limb shows a pyramidal pattern of weakness, grade 4 in shoulder abduction and elbow extension, grade 5 elsewhere. Now reflexes. For the upper limb, test the biceps, triceps, and supinator reflexes. Use a tendon hammer. Ensure the tendon is in the correct position and the patient is relaxed. Strike briskly and watch for the reflex response. For biceps reflex, which is C5/6, place your thumb on the biceps tendon in the antecubital fossa and strike your thumb result in elbow flexion. Secondly, supinator reflex, which is C5/6. Strike the lower radius about 2 centimeters above the wrist. The forearm supinates and the elbow may flex slightly. Lastly, triceps reflex, C7. Support the forearm and strike the triceps tendon above the olecranon. The elbow extends. Grade reflexes as absent, diminished, normal, brisk, or very brisk with clonus. Upper motor neuron lesion. Reflexes are brisk, hyperreflexic. Lower motor neuron lesion. Reflexes are diminished or absent at the level of the lesion. Check for finger jerks. Tap the flexor tendons in the palm with the patient's fingers slightly flexed. Positive finger jerks, flexion of all fingers, suggest brisk reflexes and upper motor neuron pathology. Hoffman sign. Flick the middle fingernail downward and release. If the thumb and index finger flex briskly, this is a positive Hoffman sign, equivalent to Babinski in the upper limb, suggesting upper motor pathology. Narrate. Reflexes in the right upper limb are brisk. Biceps, triceps, and supinator all increased. Hoffman sign is positive on the right. Coordination checks cerebellar function. Ask the patient to perform the finger-nose test. Touch your nose with your index finger, then touch my finger. Hold your finger about arm's length away and move it to different positions. And watch for intention tremor, tremor that increases as the finger approaches the target. This is a cerebellar sign. Secondly, check past pointing. The patient overshoots or undershoots the target. Lastly, dystiadochokinesia. Ask the patient to rapidly alternate hand movements, tapping the back of one hand alternately with the palm and dorsum of the other. Slowness, arrhythmia, and breakdown of this rapid alternating movement is a cerebellar sign. Rebound. Hold the patient's outstretched arm against resistance, then suddenly release. A normal person checks the movement. A cerebellar patient overshoots. This is the rebound phenomenon. For sensation, you have to check 4 modalities, brief but important. In the upper limb, test at minimum: light touch, pinprick, vibration, and proprioception. Light touch, use a cotton wool wisp. Test distally first and move proximally. Always compare sides. Pinprick, use a neurotip. Does this feel sharp or dull? Compare sides. For vibration, use a 128 Hz tuning fork. Place on the distal interphalangeal joint first. Can you feel it buzzing? If absent distally, move proximally to the wrist, elbow, sternum. Lastly, proprioception. Hold the distal phalanx at the sides, not the top and bottom, as this gives pressure cues. Move it up or down. Which way am I moving it? Loss of vibration and proprioception with preserved pain and temperature suggests dorsal column pathology. For example, subacute combined degeneration or multiple sclerosis affecting the posterior columns. Glove and stocking loss of all modalities distally suggests peripheral neuropathy. The lower limb examination follows exactly the same sequence as the upper limb: inspection, tone, power, reflexes, coordination, and sensation, but with a few important modifications. Position the patient lying flat on the couch, legs fully exposed. General inspection. Look for asymmetry, wasting, particularly of the quadriceps and calf muscles, fasciculations, foot drop, pes cavus, skin changes, scars. Pes cavus is, a high-arched foot, is an important sign. It suggests a hereditary peripheral neuropathy, most commonly Charcot-Marie tooth disease. If you see pes cavus, look at the patient's hands for similar wasting, the classic inverted champagne bottle, lower legs. For tone, pick up each leg and roll it. Roll the thigh rapidly from side to side and watch whether the foot moves freely. Then lift the knee sharply. In a normal leg, the foot drags along the bed. In a spastic leg, the foot lifts off the bed because tone is increased. Check for ankle clonus. Dorsiflex the foot sharply and hold. Sustained rhythmic contractions, more than 3 beats, indicate upper motor neuron pathology with hyperreflexia. For power, check hip flexion, hip extension, knee extension, ankle dorsiflexion, ankle plantar flexion, and great toe extension. Upper motor neuron pattern in the lower limb. The flexors are relatively weak. You will find weakness in hip flexion, knee flexion, ankle dorsiflexion, and toe extension. The extensors are relatively strong. The leg adopts an extended, externally rotated posture, the classic hemiplegic or paraplegic leg. Reflexes, knee jerk, L3/4, ankle jerk, S1, and crucially, the plantar response. The plantar response, use an orange stick or key. Stroke firmly along the lateral border of the sole from the heel toward the little toe, then curve medially under the ball of the foot. Normal response, the toe is flexed downward. Abnormal response, Babinski sign, is extension of the big toe, often with fanning of the other toes. Babinski is a sign of upper motor neuron pathology. Let's move to coordination, heel-shin test. Ask the patient to place the heel on the opposite knee and slide it down the shin to the ankle, then back up. A cerebellar lesion produces an inability to maintain a straight line. The heel wanders off the shin. For sensation, same sequence as upper limb. Test to a dermatomal level if there is a sensory level. Start distally and work up until sensation returns to normal, then note the level. For Romberg's test, ask the patient to stand with feet together, arms by their sides. First, with eyes open, a cerebellar patient will sway even with eyes open. Then with eyes closed. Romberg's is positive if the patient is steady with eyes open, but sways significantly with eyes closed. This indicates dorsal column or proprioceptive loss, not cerebellar disease. A positive Romberg's means the patient was compensating visually. Lastly, gait. Always ask to observe the gait if time permits. May I just watch you walk to the end of the room and back? Gait is enormously revealing. We will cover specific gaits with each case. Now, the thing most first-time candidates get wrong: how to present neurological findings. The framework I want you to use every single time is this. 1-sentence summary. State the pattern of findings. Then systematically go through tone, power, reflexes, coordination, sensation. Then your conclusion. What syndrome does this represent? Then localization. Where is the lesion? Then etiology. What is the most likely cause? Let me show you what that sounds like. I will use an example of a right-sided upper motor neuron lesion. On examination of the upper limbs, I found signs consistent with a right-sided upper motor neuron lesion. Tone was increased in the right upper limb with a spastic quality. Power showed a pyramidal pattern of weakness, grade 4 in shoulder abduction and elbow extension on the right, with relative preservation of elbow flexion. Reflexes were brisk throughout on the right, biceps, triceps, and supinator, with a positive Hoffman sign. Coordination was intact. Sensation was reduced to light touch and pinprick in the right upper limb. In summary, these findings are consistent with an upper motor neuron lesion affecting the right upper limb. Given the unilateral involvement with ipsilateral signs, this is most likely a central lesion. The most likely differentials would be a previous cerebrovascular accident, a stroke, or space-occupying lesion. That is the structure. Summary. Findings in order. Conclusion. Localization. Aetiology. Do not mix these up. Do not start with sensation and then go back to tone. Do not give findings without a conclusion. Do not conclude without localizing. The examiner is expecting this structure. Give it to them clearly. Since presentation is where most first-time candidates lose marks in this station, let me be very specific about the 4 mistakes I see most often. Mistake 1. Presenting findings in random order. The reflexes were brisk. I couldn't feel vibration. The tone was a bit stiff. I think there was some weakness, and coordination seemed okay. That is not a presentation. That is a list. Go in order. Tone, power, reflexes, coordination, sensation. Always. Mistake 2. Not giving a conclusion. presenting findings without saying what syndrome they represent. The tone was increased, the reflexes were brisk, there was a Babinski sign. And then stopping. The examiner is waiting. You must say, these findings are consistent with an upper motor neuron lesion. Give the conclusion. It is not optional. Mistake 3. Not localizing the lesion. This is the second most common failure point. You gave the conclusion, UMN lesion. Good, but the examiner wants to know, where? Unilateral UMN in the arm means a contralateral hemispheric lesion. Bilateral UMN in the legs means a spinal cord lesion. Cerebellar signs are ipsilateral to the lesion. Learn the rules and apply them every time. Mistake 4. Presenting only positive findings. Say what you found, but also say what you did not find. There was no sensory loss. Coordination was intact. Reflexes were equal and normal bilaterally. Negative findings are as important as positive ones. They help rule out differentials and show the examiner you examined thoroughly. The fix for all 4. Use the structure. Every time. Summary. Tone. Power. Reflexes. Coordination. Sensation. Conclusion. Localization. Cause. Neurology is the examination that improves most with repetition on real patients. Here is how to practice effectively. Number 1. Practice the routine on a colleague every single day. Upper limb and lower limb. Time yourself. Upper limb should be under 4 minutes, lower limb the same. Do this until the sequence is absolutely automatic. You should not have to think about what comes next. Number 2. Practice presenting immediately after every examination. Out loud, with the full structure, summary, findings in order, conclusion, localization, cause. Record yourself. Listen back. Are you leading with the conclusion? Are you localizing? Number 3. See real neurology patients. Ward round, outpatient clinic, neurology referrals. Every patient with neurological signs is a PACES case. Ask to examine them, present to a senior, get feedback. Number 4. Learn the 4 presentations by heart. Write out the 4 example presentations. Memorize the structure. Practice saying them until they sound natural, not recited. 5. Know your upper motor versus lower motor neuron table cold. Every PACES examiner will test this. Tone, spastic versus flaccid. Reflexes, brisk versus absent. Plantar, extensor versus flexor. Wasting, absent versus present. Fasciculations, absent versus present. Know all of these instinctively. 6. Practice the cerebellar signs specifically. Finger nose, heel shin, distiadochokinesia, gait, Romberg's. These are distinctive and rewarding to demonstrate well, and many candidates underperform here simply through lack of practice. Thanks for watching, stay tuned for next video. Do comment regarding any difficulty in real life. Good luck for the exam.